Good evening, Deepak sir. Can you hear me?
Yeah, hi, good evening. Yes, I can hear you.
Yes.
Good evening, sir. Pallavi this side.
Yeah, hi, good evening, Pallavi.
Yes, sir. Sir, let me remind other doctors. Give me 5 minutes, sir.
Yeah, sure.
Hello, Dr. Deepak. Good evening.
Hi, good evening, Dr. Dipesh. How are you?
I'm fine, sir. How are you?
I'm also good.
Yeah, sir. Shall we try sharing your slides once?
Yeah, we can do that.
Yeah. So you have the slides ready with you, no?
Yeah, the slides ready. Just. I hope it's visible.
Yes. So you can scroll it once just to see if there is any issue with animation or any other thing, colors. Yeah, I think so. They are running fine. Yeah.
I've removed some slides, so I
Okay.
hope to save some time.
Sure. That will be fine.
Anything else discussed during that dry run?
No, I think the only two things were like to understand the platform. Are you
Okay.
getting display? And second thing is in terms of flow. Obviously, I will welcome moderator and panelist, and then Dr. Vishalakshi would take over.
Mhm.
She would introduce panelist, and then she will hand it over to you.
Okay. Okay. Great.
The flow. So as of now, you can keep your video off. No issue.
Okay. Thank you.
Thank you. Hello, ma'am. Good evening.
How are you, Dipesh? Good.
I am fine, ma'am. How are you?
Okay. We
I
are the
missed your
only.
message actually.
Sorry,
I missed your SMS. You sent me
I
SMS.
know yesterday. Then
Actually, it
evening.
was an early morning. I saw it early morning and then I slept. And then I
Wow.
got it completely.
I was busy in the evening, so then I had to work at night to
Okay,
just because
got it.
might as well talk about your product also, right?
Yeah.
Any good topical aliconazole? I mean, I think it will be in short only. We'll just discuss that it's better than ketoconazole. Studies have proved it. उतना ही
Yeah.
बोलेंगे ना?
Oh, I think that's it as of now. And then, yeah, and after the scientific talk is over,
हाँ,
we're talking for a minute, not more than that, over the product itself. That what is the product?
great,
What are some
great,
benefits? That's it.
great, wonderful. Who else has joined?
Dr. Deepak had joined.
Hi, Dr. Deepak.
Yeah.
Hi, Dr. Preeti. How are you?
I'm fine. How are you?
I'm also good.
Great.
Hi.
Oh, finally, I can see you. Hi. Where are you based?
I'm in New Delhi.
Okay, you're going to be speaking today.
Yeah, I'll be speaking to you. Thank you so much.
How is the Delhi scene? काफी लोगों को हो रहा है ना उधर?
Yeah, the situation is pretty bad.
सुना है. I have a lot of patients there. They've been telling me.
Okay. Yeah, you are in Mumbai, right?
I'm in Bombay.
So how is it there?
It's reducing now. I knew a lot of my patients, they couldn't come to the clinic because they said I've got COVID and they were in quarantine, but not too many symptoms. And of course, beds are not available. The older generation is definitely going to hospitals, but the younger ones were fine. And now they've reduced. I mean, the cases are reducing also.
That's nice actually, but like
Yeah.
in Delhi, I think it is more or less increasing only.
Oh God,
And
still.
there are no beds, and even the younger are falling severely ill. So
Right.
Yeah. I also read about that news. Batra Hospital. 11 patients, including head of the department.
yeah, so I think it's really bad.
Sad.
So OPDs are running, or is it teleconsultation as of now?
No, it's teleconsultation only.
Okay.
I go only occasionally, like twice a week.
Okay.
That also my patients को बराबर से screen करती हूँ कि either they've healed from COVID or they've not had any symptoms. Then only I go. Otherwise, I don't see them.
Yeah.
Right. Actually, it's very tricky in Delhi because I did PRP for 2 patients and they telephoned me 2 days after the PRP that some of their family members is positive. So I mean, it's very tricky. Even
Very
if the
tricky.
patient is normal, maybe some of the other family member or some friend or some relative is infected. So I've stopped it altogether.
Actually, really.
Better to do it.
पता नहीं चलता. Later, after 3 days, they'll become positive. So then we are at stake.
Exactly. And like, I mean, there is no way to tell, sometimes the patient is looking really like healthy. There is no temperature raise, nothing symptom. And then like 2-3 days after that, they'll phone you and, ask you whether, some of, where did they catch the infections? So they also like, sometimes suspect whether they caught it from the clinic or.
From the clinic, yes.
Good evening, Dr. Arati.
Good evening.
Hi, Dr. Aarti.
Hi, Dr. Aarti.
All well?
All
Yeah,
well.
all well. How are you?
Yeah, I'm good. Are you doing your clinics regularly?
That's
No,
what we're discussing, that occasionally only, not Delhi तो उन्होंने डॉक्टर दीपक ने बंद ही कर दिया है.
हाँ, Delhi तो it's really bad. Even Kolkata is bad. यहाँ पे भी beds नहीं मिल रहा.
Okay.
But oxygen supply है. People are getting oxygen, but there is a dearth of beds.
I'm just going once or twice a week only for like known patients who are, not having any symptoms, nobody in the house, they've not got out of the house. तो ही मैं उनको मिलती हूँ. Otherwise, I do only phone consult.
मेरे तो बहुत पेशेंट्स अपॉइंटमेंट कैंसिल कर देते हैं, बोलते कि कोविड हो गया. ठीक है, बताओ.
Even so many of my patients got COVID. They were like in quarantine. They couldn't get out. So कभी-कभी मन में लगता था जाऊं नहीं जाऊं, and then सामने से वो बोलता है COVID. I'm like, okay, thank you. You didn't come. बच गए. और एक पेशेंट फिलर के लिए पीछे पड़ी थी. मैंने बोला तेरा पैसा नहीं चाहिए मेरे को, तुम बता. We'll do it later. Can't take a chance, yeah.
Hello, good evening, everyone.
Good evening.
Hi, good evening.
Yeah, Dr. Bhakti. She is my colleague from Lupin.
Hello.
So Dr. Bobby won't be able to join today.
Acha.
Again, because of someone having COVID in his family.
IDVL का आप अटेंड कर रहे थे अभी पिगमेंट्री डॉक्टर आरती डॉक्टर दीपक?
No.
मैंने अभी 4 o'clock चालू तो किया है बट ऑफ कोर्स आई रिड्यूस द वॉल्यूम बट
today
पिगमेंट्री का है ना उनका
4 to 7 I think. Yeah.
जी 4 to 7 so we should wind up at 6 and get back to hearing this.
Yeah, we will do that.
Yeah, hopefully.
Because हमारे व्यूअर्स ज्यादा होंगे भी नहीं वैसे भी डॉक्टर्स आधे यहाँ होंगे.
Ma'am is
okay. Is that fine? Yeah. Okay. Yeah. Okay. Yeah. Bye. Thank you.
Hi doc.
Hi.
good evening, ma'am.
Good evening, ma'am.
Hello. Some confusion last moment as usual. Anyway, good evening to all of you.
I
जी.
What's happened to Dr. Bobby?
I think one of his family members got COVID.
Okay. Hi, Deepak, all set?
Yes, ma'am, all set.
Okay. Do you, any of you want me to ask anything particular on any other topic specifically? Or we can just take it, anyone can take the question. Is it fine?
I think
Yeah, I think.
anyone should be okay.
Should be okay?
Yeah.
हाँ जिसको ज्यादा जल्दी आ रहा है आंसर वो हाथ उठा के बोल दो. तो हाथ उठा के करोगे अनम्यूट करके बोल दो.
अरे practical points बताओ. I mean that is the main thing.
I was just telling the others that वो IDVL का चल रहा है ना पिगमेंट्री.
हाँ.
So we should finish at 6 sharp and get back to hearing that.
I was on that also. I just.
हाँ मैंने 4 बजे चालू कर दिया.
हाँ रश्मि का हो गया. I think the next one is going on.
Right.
The audio is clear, right? No
Yes,
problem,
ma'am.
right?
It's clear. We'll take up all audience questions at the end.
Yeah.
Yes.
So I'll be seeing it on the chat box only, right?
Yes, ma'am.
Yeah.
Because audience questions don't come directly here. Our tech team will post it here.
Yeah, you just post it and you can also ask it or you put it on the chat box or whatever.
Yeah,
Then
it will be visible to everyone.
Yeah.
Comment chat box.
Okay. Yeah.
So it's going to be only 4 of us, huh?
Yes.
Okay, it's okay, right?
Yes, ma'am. It was visible.
Yeah, come later because I'm in a webinar now, 5 to 6.
There's no organ.
It is all there up, whatever is there. Oregano is not there. No. We got one mix something. We start sharp at 5, is it?
Yes, ma'am. We'll start sharp at 5. So in the beginning, we will have a very short clip from Lupin. Then I will welcome audience and introduce you. And then you can take over and just briefly introduce panelists.
Yeah.
Then followed by Dr. Deepak's talk.
Oh,
And at the end again, I will show that same clip
okay.
for 30 seconds.
Fine.
Dipesh sir, can we go on live?
Just 1 minute more.
Okay.
As soon as it's fine, you can start the video.
And you can see how many people have joined already, Dr. Dipesh?
Not me, because we are using panelist link. I think
Okay.
technical team.
20 people have joined.
Okay.
Should wait.
Thank you.
I think it's 5 o'clock. Pallavi will start then. Correct?
Okay, yes, yes.
Yeah. So Chetan, you can start with video clip.
Yes, sir. Yes, Dipesh sir, over to you.
Okay. Very good evening, everyone. I'm Dr. Dipesh Sonone, Senior Manager Medical Affairs at Lupin. On behalf of Lupin, I welcome you all to this interesting webinar on scaly conditions of the scalp with focus on seborrheic dermatitis. For today's webinar, I'm pleased to welcome our moderator, Dr. Vishalakshi Vishwanath. Dr. Vishalakshi is a senior faculty from Thane, Maharashtra. She is currently professor and head Department of Dermatology at Rajiv Gandhi Medical College, Thane, Maharashtra. She is also founder member and medical director at Disha Skin and Laser Institute. So welcome, ma'am, and I hand over the session to you for further proceedings. Thank you.
Thanks, Dr. Dipesh. Very warm welcome to all the audience. We are having an interesting session on scaly conditions of the scalp with a focus mainly on seborrheic dermatitis. We have a young panel with us, Dr. Deepak Jakar, who is from Delhi, Dr. Preeti Savardekar from Mumbai, and Dr. Aarti from Calcutta. So we actually had Dr. Bobby also, who couldn't join because of some medical issues. Warm welcome to all of you, and let's have an interesting talk. And we begin right away with Dr. Deepak.
Thank you, Dr. Vishalakshi. So good evening to everyone. So I'll be sharing my screen. And we'll be starting with a talk on the various scaly conditions of the scalp with focus on the seborrheic dermatitis. So scaly scalp, as we know, is a very common clinical presentation, and we see a lot of patients in our clinical practice. This scaling can be attributed to multiple etiologies, and we'll be discussing about these etiologies in detail in my subsequent slides. The usual approach, to the differential diagnosis of these scaly conditions of the scalp starts with taking of a proper history from the patient and reaches up to the clinical examination, and then further, if required, we also go for certain lab investigations. The common symptoms that these patients present with is erythema pruritus, fine to severe kind of scaling, and in some cases also crusting as well as oozing of the scalp. There are various differential diagnoses as far as the scaly condition of the scalp is concerned, and majorly they include psoriasis, tinea capitis, atopic dermatitis, contact dermatitis, but the most important and the most common that we see in our practice is the seborrheic dermatitis. The relationship between the seborrheic dermatitis and the term dandruff is again a very controversial issue. There is one school of thought which says that dandruff is just a milder form of seborrheic dermatitis, whereas there is another school of thought which says that dandruff is a lay term which includes any condition that has very fine scaling over the scalp. So this terminology is confusing, but for this talk and for this session, we'll consider dandruff as a very mild form of seborrheic dermatitis. And as we all know that, both these conditions leads to significant psychological trauma manifesting in the loss of self-esteem by these patients and generation of a negative social image. So as I've discussed, most investigators regard seborrheic dermatitis of the scalp as a severe dandruff, or vice versa also dandruff as a very mild form of seborrheic dermatitis. So what is the basic difference is that is being highlighted in these images. So in the normal scalp, it is very usual to see very, very fine scales, but there is no itching or there is no symptom because of these fine scales. When flaking and itching starts, then we start saying that it is the manifestation of a dandruff. And when there is visible irritation, when there is visible erythema, when there is visible inflammation, then we say that this condition has led to seborrheic dermatitis. So seborrheic dermatitis, the incidence and prevalence worldwide is 3 to 12% of the total population. It is said that the general adult population, it is somewhere between 1 to 2%. It increases in the immunocompromised patients where it reaches up to 83%. And in children also, the prevalence is slightly higher than the adult population, which is usually more during the infancy and start decreasing as they age. As far as the dandruff is concerned, the prevalence is somewhere between 30 to 95%, and an extrapolated prevalence of dandruff in India is 195 million. There are certain species which have been isolated from seborrheic dermatitis and dandruff in Indian population, and they majorly include Malassezia globosa, restricta, furfur, sympodialis, and sloophy. It is also found that as the density of these species on the scalp increases, it is correlated with the severity of the dandruff or the severity of the seborrheic dermatitis. There is geographical variation in these Malassezia species, and it is found that in the northern part of India, the Malassezia globosa and restricta are the major species, and as we move down towards the south, Malassezia furfur becomes the significant species, in addition to the globosa and the restricta. Now, it is also related to the severity of the dandruff, as we can see, as highlighted by the red blocks. So we see that the severity is moderate to severe when the species are globosa and restricta, and in southern part, it has been found to be moderate when the species is furfur. Now there has been people have found association between the presence of these Malassezia species on the scalp with the individual susceptibility of the individual, which includes the immunity, the epidermal barriers, the genetics of the individual, the neurogenic factors, emotional stress, nutrition, and other factors, along with the activity of these sebaceous gland activities. So all these are interrelated, and we see that whenever one thing is increased, it leads to the increase maybe like increase in the sebaceous gland activity can lead to increase in the Malassezia colonization, and henceforth the symptoms of seborrheic dermatitis. The clinical presentation, it varies from mild to moderate to severe cases, and usually presents as a greasy papillosquamous lesion. They can be seen on the scalp, the nasolabial folds, the external ears, eyebrows, eyelashes, basically all the sebum-rich areas which are there in the body. These classical greasy papillosquamous lesions can be seen in those areas. The clinical appearances in the scalp may vary differently, because you can have a very mild case where there's just scaling and very minute erythema, to a very inflamed scale with even the presence of small pustules. Now, dermoscopy or trichoscopy has opened up another domain, and it has eased out the clinical differentiation and clinical diagnosis of seborrheic dermatitis. So over the left-hand side, if you can see the image, there is very slight white to yellowish colored scales which are present in between the follicles. So interfollicular presence of white scales, and these scales may even be present around the follicles. So as the severity increases, the thickness as well as the color of these scales becomes more yellowish, more from whitish to yellowish. You can see more of crusting, more of erosions over the scalp. And the typical vessel, the vascular morphology in seborrheic dermatitis is that of arborizing vessels. Of course, you can see dotted vessels also and linear vessels also, but the more typical vessel is the arborizing vessel, which also helps you differentiate this condition from psoriasis, as we'll discuss later on. Another variant of seborrheic dermatitis is the infantile seborrheic dermatitis, which often presents in the first month of life, and it markedly involves the face and the flexural areas. It is also considered to be an early variant of atopic dermatitis. Studies have found that the patients who have seborrheic dermatitis early on in their first month of age are more prone to develop atopic dermatitis later on. Cradle cap is again a severe form of infantile seborrheic dermatitis, and it has been found to be associated with the colonization of malassezia, as I was earlier discussing, that as the number of species, as the density of these species increases over the scalp surface, the severity of the presentation also increases. As far as the differential diagnosis goes, to me, psoriasis, atopic dermatitis, and tinea capitis are the most common differentials. A proper history taking, clinical examination, family history, examination of other sites, all these factors helps you differentiate these psoriasis, atopic dermatitis, tinea capitis from seborrheic dermatitis. So psoriasis, it usually involves the extensors, the palmar, plantar, and the nail and the external and the extensor areas are predominantly involved. The plaques are thicker as compared to the seborrheic dermatitis, and they are sharply limited with a silvery white scale. So that is very typical of psoriasis. You can find a positive family history, and of course, the presence of arthritis can also be seen in 10% of these patients. As far as the atopic dermatitis goes, it first appears after 3 months of age. Pruritus and restlessness are very common. Mind you, pruritus is not a very common symptom of seborrheic dermatitis. It is usually seen, but it is not considered to be a major symptom of seborrheic dermatitis. So again, pruritus can help you differentiate atopic dermatitis from seborrheic dermatitis. A very severe pruritic lesion might be an atopic dermatitis lesion as compared to a seborrheic dermatitis. And it frequently involves the scalp, cheeks, and the extensor areas. The flexural areas are more seen in the older individuals as the child ages. And you may find a family history of atopy such as eczema, allergic rhinitis, or asthma. As far as the tinea capitis goes, it is more commonly seen in the children, frequently accompanied by the hair loss patches. It can be a black dot variant or maybe a gray patch, and it is highly contagious. Of course, if you're suspecting tinea capitis, you have to go for the KOH examination to see for the presence of these fungal elements in the hair shafts. And even if the KOH is negative and you are strongly suspecting that it is tinea capitis, you should always go for a fungal culture. So the management part of seborrheic dermatitis is basically divided right from what is the cause. Like in this case, it can be either the presence of the malassezia species or maybe increased secretion of the sebaceous lipids. So the management will include, if you're suspecting a malassezia species, you might consider adding an antifungal, a topical antifungal, or maybe antifungal shampoos to your management. And if you are suspecting excess of lipid secretions, then you might consider adding a sebum suppressing agents. Then there is hyperproliferation, as is evidenced by the presence of scales. So you might consider adding anti-proliferatives such as the coal tars or anti-inflammatory agents, as I'll discuss later on. And for the presence of flakes, again, you can use the keratolytic agents like the salicylic acid, which will help in the removal of these scales, as well as it is going to potentiate the penetration of these topical antifungal and anti-inflammatory agents. So the goals of the treatment in case of seborrheic dermatitis is not just to alleviate some signs and symptoms of the condition, but it is also to promote the normalization of the skin structure and the function. Then it is also intended to improve the quality of life of these patients, as many of them may suffer from a low self-esteem. And you have to counsel your patients that even after treatment, there is a very high chance that this condition might recur in future. Now, there are several other factors that have to be taken in mind as far as the Indian population is concerned, and there are a number of sociological, economical, and cultural differences which have to be taken into account. You have to consider the fact that the patient might come after treatment from over-the-counter medications, or maybe use of cosmeceuticals or generic medications. And there are also certain, treatments which these patients might be taking from the beauticians or maybe at home or some other non-healthcare personals, thereby increasing the risk of irritation and as well as inappropriate treatment in the patients. You also have to suggest the lifestyle modifications, and it has been found that high adherence to the Western dietary pattern in females is associated with a more seborrheic dermatitis. Anti-inflammatory dietary approach has been advocated, and it has been advised to reduce the intake of refined carbohydrates, then avoiding foods that promote yeast growth, such as the bread, cheese, wine, and beer has to be advised. It is also advised to take an omega-3 supplement and to take a good quality multivitamin, possibly adding extra biotin as well. So this is the proposed therapeutic algorithm for the management of seborrheic dermatitis, and it has been divided into a mild seborrheic dermatitis and moderate to severe seborrheic dermatitis. I'll discuss them in detail in my subsequent slides. Basically, what we need to understand whenever we are dealing with the treatment of any dermatosis is what is the level of evidence for any particular therapeutic agent as far as the management of that condition is concerned. And it has been found that the topical antifungal agents, the topical corticosteroids, and topical calcineurin inhibitors, they have been found to have a level of evidence A, which is very high, which is the highest level of evidence for seborrheic dermatitis, and you should consider these agents in one or as a solo or a combination therapy. So how do you manage a mild seborrheic dermatitis patient? So in the management of mild seborrheic dermatitis patient, it is usually advocated to go for topical therapies. And the most commonly used are the topical antifungals, which can include shampoos or the foaming gels. And these can include cyclopirox 1 to 1.5% shampoos or ketoconazole 1 to 2% shampoos. You can also add on anti-inflammatory agents with antifungal properties, such as the pyroxone or bisabol or the lactoferrin shampoos. Keratolytics might be added if you have very severe scaling and you need to get rid of that scaling for the other therapies to penetrate. And there are certain other agents also which have been added into the shampoos, like the selenium sulfide 2.5% and zinc pyrithrone. Now, the use of topical corticosteroid is the second step in mild seborrheic dermatitis. You should always try to maintain, or you should always try to manage your cases with the topical antifungals or topical anti-inflammatory agents first, and then go to the topical corticosteroids. The duration as well as the application of these agents are usually twice or thrice weekly. And in case of topical steroids, when you're resorting to the topical corticosteroids, they're usually once daily, and the duration may range from 2 to 4 weeks. So these are the various topical antifungals. Ketoconazole 2% shampoo, it has to be applied twice weekly for 4 weeks. Intermittent use has also been advocated, especially for prevention of relapse and to maintain the therapeutic resolution of seborrheic dermatitis. The safety profile is very much on a safer side for ketoconazole 2% shampoo. The only adverse effects which have been reported are the irritation and the pruritus. Cyclopirox 1% shampoo is again a very good therapeutic modality if you are not going for ketoconazole 2%. Again, the dosage is twice weekly. And again, in the maintenance phase, you can go for once a week. Again, the adverse effects are burning contact, dermatitis, and pruritus. Pyroxone olamine is also having an anti-inflammatory properties along with the anti-fungal properties. So again, if you are seeing a patient who has more of inflammation as compared to just scaling, so you might consider going for pyroxone olamine. The application is again twice a week. Keratolytics most commonly used are the salicylic acid 3% shampoos and tar 1 to 2% shampoos. Always be sure when you are using tar 1 to 2% shampoos, because there is very high risk of development of folliculitis or contact dermatitis and even photosensitivity in these patients. Other agents include the selenium sulfide 2.5% shampoo. The application is again 2 to 3 times a week. Zinc pyrithrone, which is usually seen in the combination, again 2 to 3 times a week. Now, there are certain challenges with the existing therapy, and as we have seen that a lot of them are associated with itching, burning sensation, and dryness. And even with selenium disulfide shampoo, you might find patients who come up with orange-brown discoloration of their scalp or the hairs. So these side effects have to be taken into account. The long-term use of topical corticosteroid again has to be avoided because they can lead to atrophy and the stria formation of the scalp. Again, compliance is a major issue with the patients. Just as soon as the patient starts seeing improvement, they start to stop the treatment and usually come up with a relapse. And of course, use of these antifungal therapeutic modalities, be it in the shampoo or be it in the gel formation, there's always a chance of antifungal resistance. So we have another new modality, new therapeutic agent, a new antifungal, which has been formulated into a shampoo, which is a laliconazole-based shampoo. So a study has found that laliconazole is slightly better than ketoconazole in the inhibition of Malassezia species, which is very much a significant factor for the development of seborrheic dermatitis. And the MIC 50 and MIC 90 has been found to be significantly lower as compared to the ketoconazole. So this again is a very good therapeutic modality which can be considered in the management of seborrheic dermatitis. Usually these shampoos have laliconazole, zinc pyridine, and salicylic acid. Again, salicylic acid is for its calotropholytic property and antibacterial and antipruritic activity. Zinc pyridine helps to promote the scalp oil balance in association with the antifungal property, and laliconazole remains the main antifungal in these shampoos. Now, moving on to the moderate to the severe seborrheic dermatitis patients, the management slightly varies. And you have to consider adding the topical corticosteroid right from the beginning. So this is different from the mild seborrheic dermatitis, where you are considering topical steroids after the use of antifungals. Here you have to use them right away from the day one. So topical corticosteroids, they can be used like hydrocortisone 1% or maybe Desonide 0.05% cream. They have to be used once daily for up to 4 weeks. Then you might want to go ahead with more potent corticosteroids if the patient is not responding, or if you are seeing that the severity of the seborrheic dermatitis is very inflammatory, or maybe presence of the pustules or the severe signs of inflammation. So you might consider adding more potent corticosteroids in the form of clobetasol propionate 0.05% shampoo. They have to be applied twice weekly, applied for 5 minutes, and they have to be continued for 2 weeks. And after that, when you are seeing the results, you have to shift towards the topical corticosteroids, which are class 1 or class 2. The addition of systemic antifungals is advocated when these patients are not responding to these topical therapeutics. And the major systemic antifungals which have been used are the itraconazole, terbinafine, and fluconazole. Itraconazole in a dose of 100 milligram have been added, and there are two basically therapeutic therapies which have been advocated. One is in the first month, 200 milligrams per day for 1 week, and then 200 milligrams for 2 days per month for the next 11 months. So this is how you kind of titrate your doses of itraconazole. As far as the terbinafine 250 milligrams capsule is concerned, you can have a continuous regime of 250 milligrams per day for 4 to 6 weeks, or you might consider going for the intermittent regime, where you give 250 milligrams per day for 12 days per month for 3 months. And then, of course, there is fluconazole 50 mg capsules, which can be given for 2 weeks. And once you start seeing the results, you can just taper off these systemic antifungals. So topical corticosteroids for moderate to severe seborrheic dermatitis are the first line therapeutic agents for seborrheic dermatitis. You might want to start when the disease is moderate with a low mid potency topical corticosteroids, and for severe varieties, you might want to go towards the high potency corticosteroids. Then you have to consider also one more major fact is that we have seen that topical corticosteroids, whenever they are stopped, these patients have more chances of relapse as compared to the topical antifungal agents. So you have to counsel your patients that they cannot stop it abruptly, they have to be tapered off. And you might even consider adding on a topical antifungal solution to maintain the therapeutic results which you have achieved. For adult scalp seborrheic dermatitis, again, high potency agents have to be used. Use of a vehicle has to be which is non-irritating and hopefully which is hydrating. So you might consider going for a moisturizing hydrogel, or maybe a lipo cream, or maybe an emollient cream, which helps in the hydration also, because we have seen that the dryness and xerosis and irritation is very much seen with these topical therapeutic agents. For moderate to severe adult seborrheic dermatitis, again, use of a mild mid to high potency topical corticosteroid solutions in the form of foams or sprays or solutions have to be used, and they are usually stopped or tapered by second week. Then use of antifungal shampoos, again, twice weekly has to be done. They can be initiated right from the beginning, or they can be added once the inflammatory component has settled in the seborrheic dermatitis. And they have to be continued for at least 4 weeks, or maybe longer than that, depending on the severity of the seborrheic dermatitis. And these are the various topical corticosteroids which have been used in seborrheic dermatitis. Betamethasone valerate, 0.12% foam. Clobetasol, 0.05% shampoo formulation. Ketoconazole, 2% shampoo. Fluocinolone, 0.01% shampoo, and also solution has been used. Now, corticosteroid shampoo, again, it has been widely used, and the most commonly used is the clobetasol propionate, 0.05%. And the second one is the fluocinolone. When you are not planning to use the topical corticosteroids in your patients, topical calcineurin inhibitors becomes a very good choice, because again, the level of evidence is very good for these. It is which is similar to the topical corticosteroids. So they can be added right from the beginning, or maybe after you've stopped the topical corticosteroids, or maybe when you started seeing the side effects of these topical corticosteroids, but you want to continue some anti-inflammatory agent, you might consider adding these topical calcineurin inhibitors. Tacrolimus, 0.1% is the most commonly used, and it has been found to be as effective as hydrocortisone, 1%. So when are oral antifungals indicated? This is a very important question, because oral antifungals might not be the first therapeutic choice in all of these patients. So wherever you have your cases where seborrheic dermatitis is widespread, the use of oral therapy is preferred, or wherever your cases are not responding to these the topical therapeutic agents, you might consider adding the oral antifungal agents in those cases. The dosing of antifungal agents I've already discussed in my previous slides, so I'll just skip it. So moving on to the management of the infantile seborrheic dermatitis, again, the use of topical antifungals in the form of shampoos and lotions have been advocated. Then there is always, it's always better to add an emollient in the form of white petrolatum ointment. But again, it's a very tricky area, because sometimes the addition of these emollients might increase the severity of these patients. So it has to be decided on case-to-case basis. Addition of anti-inflammatory with antifungal properties, again, is a very good choice, especially when the inflammation component is there in seborrheic dermatitis. For the non-scalp areas, topical antifungal creams and topical corticosteroids might be preferred. Now, I'll just go over with the overview of the other scaly conditions and how they are treated. Rest we'll discuss in the panel discussion. So scalp psoriasis, there are two phases. One is the induction phase, and then there is a maintenance phase. The major therapeutic agents here are vitamin D3 analogs and corticosteroids. As we move from mild to severe varieties, the use of corticosteroids increases. And in milder cases, the topical vitamin D3 analogs are usually added. Then you can use shampoo, lotions in various combinations. And the use of phototherapy or radiotherapy and systemic therapies can be decided on case-to-case basis. Then on maintenance therapies, usually it is advocated to start off with the corticosteroids and then probably move towards a combination of corticosteroids or vitamin D analogs, or maybe a solo vitamin D3 analog. Tinea capitis, again, depends on the whether it's an ectothrix or an endothrix. So for an ectothrix, the drug of choice is griseofulvin. For an endothrix, you might consider going for the terbinafine, or even azole antifungal medications like itraconazole or fluconazole may be considered. Topical treatment alone is not recommended, because we have seen that these cases usually do not respond without the oral antifungal agents. And in specific conditions like the Kirion, we might even need the anti-inflammatory treatment with the addition of systemic steroids or even the topical steroids for the very short duration to help reduce the inflammatory response, and also to consequently lower the risk of permanent alopecia in Kirion. Atopic dermatitis again depends on the severity, and in the milder cases, usually just the use of topical corticosteroids or the topical calcineurin inhibitors may be enough to arrest the disease. In severe cases, of course, you might consider adding short course of oral steroids in these cases, and then second line treatment and the third line treatments in the form of cyclosporin, azathioprine, or maybe methotrexate might be considered to arrest the disease. So thank you so much.
Thank you very much, Dr. Deepa. We'll now go on to the panel discussion. Dr. Deepak has made my task easy since he's outlined most of the management modalities. But what we will do in the panel discussion is we will go on to the practical aspects of scaly conditions of the scalp and with a specific focus on seborrheic dermatitis. So as we have seen, it can represent a spectrum of disorders from dandruff to severe conditions like psoriasis. Now, most common symptoms, what we have discussed, what Dr. Deepak has mentioned is erythema, scaling, crusting, burning sensation. Do you encounter patients complaining of pain or hair loss with a scaly scalp? And does it give you a clue to any etiology? Dr. Deepak?
We do see patients where they usually complains. I mean, hair loss is more common than the pain. So even patients with seborrheic dermatitis, I've seen patients are complaining of an increased hair fall, which is different than what we see in cases of tinea capitis, which again can present with hair loss. So in case of seborrheic dermatitis, usually there is a diffuse involvement, and the hair loss is again not very patchy, which is usually seen in tinea capitis. So it does give us a clue towards when we are examining and when we are taking a history to what kind of pathology we are dealing with. So a patchy hair loss with a patchy hair loss with a lot of maybe scaling, then that would indicate towards tinea capitis, as compared to a diffuse kind of a scaling, which is slightly yellowish in color. The crusting is slightly yellowish in color. So that will point towards seborrheic dermatitis. In cases of psoriasis also, I've seen patients complaining of hair loss. But again, like we have to tell these patients, any inflammatory scalp disorder can lead to some sort of hair loss even after the condition has resolved. So they have to be counseled about that.
Dr. Aarti, do you see this complaint of hair loss during the early stage of the disease or in recurrent episode or late stage? Any clues to that?
There are many patients who complain of hair loss, and usually in the early stages, they complain of hair loss.
Gender-wise, any difference? Females or males? Like
hair loss more than the males.
So what is your approach to making a diagnosis of the scaly scalp, Dr. Aarti?
First of all, it's the history. So we need to ask about the onset of the disease, the duration of the disease, then whether there is any history of atopy, whether there's any family history, whether there's any seasonal variation, any systemic illness, any neurological problem like Parkinsonism, Alzheimer's, stroke, if the patient is on any medications. After taking a thorough history, we need to do a clinical examination in which we need to see the type of scale, whether it's a micaceous scale or whether it's a greasy scale, whether there is any underlying erythema or the plaques are well defined. So the clinical examination should be done really well, and you need to look for the lesions elsewhere also. Apart from the scalp, you need to see whether other areas of the body is involved or whether the nails are affected. And for after the examination, we go into lab investigations. In lab investigation, generally I do a trichoscopy, which helps in differentiating between seborrheic dermatitis and psoriasis.
Dr. Preeti, do you often do a trichoscopy in your patients?
A trichoscopy also, because I think that is the main differential factor right now available. Earlier, when we didn't have trichoscopy, we were still dicey whether it is psoriasis, whether it is seborrheic, because in some cases the greasiness and the yellowness is not very prominent if they've washed their hair and come and they are dry. So sometimes you can have an oily scalp, but you can have a dry scalp too. But now with the trichoscopy, it becomes much easier to confirm, because you'll see the hidden hairs, you'll see the arborizing vessels, you'll see the comma vessels, which is common in seborrheic, whereas the signet cell vessels, which are present in psoriasis. So, it becomes much more easier to confirm with the trichoscopy now.
In the COVID scenario, Dr. Deepak, how often do you do a trichoscopy? And is it that like you prefer a handheld dermatoscope or you use a video dermatoscope during your clinical practice?
I have both actually, handled as well as the video dermatoscope. But during COVID, I have restricted to a very few patients who actually require it. We have published 2 articles regarding the use of dermoscopy during the COVID times and how they can be used. So I think wherever it can be avoided, it should be avoided, because ultimately, whether it's a video dermatoscope or the contact dermatoscope, it requires a close proximity to the patient. So, in my opinion, it has to be avoided during these times.
Opinion of Dr. Aarti and Preeti? Yeah, Dr. Preeti?
So what I would usually do, I stand at the backside of the patient and examine the scalp. And I also use a cellophane paper to put on the scalp first and then put my dermatoscope on it. So that makes it quite convenient. At least, you have a little clarity on what you want to start with.
If it is one condition of the scaly scalp you want to diagnose by trichoscopy, I mean, which condition do you think is most important?
I think for seborrheic, because psoriasis it's very clear and evident when you see the silvery white scales, and they complain of so many scales falling. But when the greasy scales of seborrheic don't fall off, you want to confirm if it is normal dandruff or if it is seborrheic. That is the time I use my trichoscope. Otherwise, I don't touch everybody's scalp with the trichoscope.
Any comments, Dr. Aarti, Dr. Deepak?
Yeah, so I think the sensitivity is more with tinea capitis.
Yeah.
So whenever you're putting your dermatoscope, at least the typical features of tinea capitis can help you define and diagnose that condition. For cases of seborrheic dermatitis and psoriasis, again, based on your clinical examination, you have to correlate it with the trichoscopic findings. So there, the sensitivity is not that much high as compared of a tinea capitis. So it depends. Like, if you are just correlating your clinical findings, then probably it is good to go for trichoscopy in all the conditions. But when you are aiming the diagnosis, I think it is best for tinea capitis.
That's what even I feel. Tinea capitis is the area where I think we don't go for an KOH mount also now. It's a trichoscopy which is most important. Biopsy, do you do scalp biopsies for scaly condition? Dr. Aarti?
Really not.
Any comments, Dr. Preeti or Dr.
Yes. No, we
blood
don't.
test? Do you ask for any blood test?
Blood tests usually I don't do, ma'am. Biopsies, yes, in certain conditions where the diagnosis is not clear.
If you have a very severely scaly scalp, severe seborrheic, you're suspecting an HIV problem.
Then, yeah. And we have to rule out immunosuppression.
Do you commonly do zinc levels and all in seborrheic dermatitis, since zinc is supposed to be useful? I don't think we hardly do. I don't think a blood test is very much important in making a diagnosis of a scaly scalp.
So with the history, Dr. Visha, when you have a good history where they say they have a stubborn seborrheic dermatitis or the scales, they've tried every different medicine available. They've visited 3-4 doctors and still they're not getting better. That is the time maybe I would think of doing some blood test. Maybe I would think of getting a biopsy. Otherwise, I think the history and your clinical examination evidently gives us what we need to do because of the pruritus, different kinds of history that you can elicit from the patient. So
now coming on to the etiology, I think Dr. Deepak has discussed it in detail. What I would like to highlight here is now there is this concept of scalp microbiome which has come, and it's not only a proliferation of malassezia, but also there is a balance between staph and Cutibacterium acnes, which definitely plays a role. And I think it does play a role even when you consider the treatment aspect, which we'll deal with a little later. Now, coming to clinical clues, how commonly do you see? Dr. Aarti, would you, if you're seeing it in a younger age, like an adolescent coming to you, how often do you diagnose it as an atopic or a seborrheic?
Seborrheic dermatitis is quite common, and yes, it is seen in infancy and also in a lot of adolescents who come with dandruff. So it is very common. So you have to rule out atopic dermatitis. So you need to ask about atopic features, whether there is any history of atopy or whether they have extremely dry skin, or you have to look for clinical features of atopy, other clinical features of atopic dermatitis to rule out atopic dermatitis.
See, you usually have this atopic children who are following up with you for a very long time. And when they reach adolescence, they come with a little bit of seborrhea and scaling of the scalp. Would you attribute it to just plain atopic dermatitis, or is there an overlying seborrheic dermatitis which has come on top?
Now there is a school of thought that seborrheic dermatitis can be a variant of atopic dermatitis and the two can coexist. So there can be coexistence of the two conditions.
Any seasonal pattern do you see in your practice, since we are all from different areas?
Sorry, can you please repeat?
Seasonal pattern, any particular seasons do you get more of seborrheic dermatitis cases?
Yes, ma'am. When, especially when the humidity is very high, I've seen patients coming up with more severe diseases. But when I take their history, they usually say that, it remains throughout the year. The severity decreases, but then there is some seasonal exacerbation only. So I think the disease remains, it just becomes mild when the humidity is less.
Dr. Preeti?
Definitely, it's present all the time, and only there are some exacerbations during the winter because of the dryness. But if the patient is seborrheic, he's going to have it most of the time. The nose corners, the ears, and especially the buttock cleft will always have some symptoms there.
Do you see any other associated cutaneous diseases? I mean, other than atopic, Dr. Aarti?
Yes, you can see acne, versicolor, hepatitis pleurum, folliculitis. So all these can be associated with seborrheic dermatitis.
Any other comorbidities or risk factors, Dr. Deepak?
Ma'am, other than for checking for the immunosuppression, I don't see much of comorbidities in these patients.
Do you really see any drug intake? I personally have not seen any in my.
It has been mentioned, but I have never seen.
Never seen. In fact, with seborrheic, I don't. I mean, with psoriasis, we do get drug intake, but with seborrheic, I don't think I've seen any in my. Any of you?
No.
No.
So how do you differentiate between normal scalp dandruff? This is like, I mean, Dr. Deepak has shown us the pictures, but when you have to counsel a patient who comes to you telling that I have dandruff, okay, and sometimes you don't see dandruff and you see a normal scalp. So how do you counsel them on this aspect? One is, how do you differentiate and how do you counsel? Dr. Preeti?
So first, I would try to even find out that whether they notice the dandruff after a few days of the wash, or whether it's, even on the day of the wash. That is very classical. I've noticed that people who have seborrheic, even on the day of the wash, after some time in the evening, they'll start getting scales on their scalp and they'll start feeling itchy. Whereas the normal dandruff will not have these symptoms. And after about 2-3 days, they start getting the scales collecting. And that's how they have to wash like alternate day or maybe 2-3 times a week. So this is one classical sign that I've noticed. And of course, you can examine the other seborrheic areas because they might not have noticed that. But if you find those, the flexural areas behind the ears, their eyebrows, you ask them for scaling on their beard, sometimes if they are young adolescent boys, and they will give you symptoms of, getting oily. And they say that I do get scales, but it's not very prominent, but yeah, I do become oily and I have to wash very often. You'll get a history from them. They tend to have a bath 2-3 times a day because they get greasy and they want to get the oil off. So when I ask, you elicit a little more history, you can judge what they have.
Any other points, Dr. Deepak or Dr. Aarti?
Besides the points told by Dr. Preeti, I think in such cases, I usually pick up my video dermatoscope so that I can show their scalp right in front of the screen. So sometimes, it's very mild dandruff or very mild seborrheic dermatitis, which might not be easily visible with the naked eye, but that can be picked up with a video dermatoscope. And, it is very common to see these patients coming, as Dr. Preeti has said, that they'll come on the same day of their head wash. So that becomes a challenge, to differentiate between the normal or the dandruff or the seborrheic dermatitis, because the scaling is almost invisible with the naked eye. So I think trichoscopy has eased out things quite a lot for us.
How often do you repeat video dermatoscopy in such patients? I mean, every follow-up, or is it?
Before COVID, I was doing in every patient.
Every follow-up, yeah.
Okay, and between seborrheic and atopic, in a child or an adolescent, I think we already dealt with this. And between seborrheic and psoriasis in an adult, sometimes you do get cases of sebopsoriasis, where at times it becomes very difficult whether it is actually a sebopsoriasis or it's a seborrheic dermatitis. Any clues to differentiate them other than trichoscopy?
So in such a case, I would, you in your counseling is very important, and the way you treat them, like try to avoid giving too much of steroid and even try home remedies. But when nothing works and you're not sure, then I have to do a biopsy to differentiate between psoriasis and seborrheic dermatitis of the scalp. I do that.
Dr. Aarti?
I generally don't do a biopsy. Generally, dermoscopy helps in differentiation, and as well as clinical examination can also help to differentiate whether it's seborrheic dermatitis or psoriasis, given the pattern of scaling and whether the plaque is well defined or ill defined, and the other areas of involvement. So these will help in differentiating.
How often do you see a family history of seborrheic compared to psoriasis?
I think family history is more common in psoriasis than in seborrheic.
Psoriasis.
Now coming to dermoscopy, I think, these are beautiful pictures which are shown, but actually when you put the dermoscope, you probably see only the scales, but a trained eye then lets you see whether there are red dots, globules, or the arborizing vessels which are specific for seborrheic dermatitis. A newer sign which has been described as a dandelion sign in seborrheic dermatitis, and they are correlated with the amount of Malassezia species which is present. So it's a newer sign which has been recently been described. Have you seen any atypical presentations of seborrheic dermatitis, any of you? During your practice, any of atypical presentations?
I would not say atypical, but stubborn, yes, not atypical.
Recalcitrant, you would mean it as a recalcitrant. When you've seen, there are some cases who are classically seborrheic and then go on to a pityriasis amiantaceae type of a picture, And there again, it is a combination of probably antibiotics along with antifungals which works in them. And you do get cases of seborrheic dermatitis who get recurrent folliculitis also at times of the scalp. So that otherwise atypical we usually see in HIV, where we see all over the body, but only on the scalp is what I wanted to know, where you do get either a folliculitis or a P. amiantaceae type of picture. Coming to therapeutic aspects, we'll be discussing regarding oil, shampoos, topical and systemic agents. Now, these are common things which patients do ask us and tell us that we are using different oils, or they have used home remedies, traditional things, salon products. So now what is, this was a study, I was interested in knowing which are the oils which have an antifungal property. So this was a longitudinal study of scalp microbiome, which showed that coconut oil is useful in maintaining a healthy scalp. It is like how our grannies used to tell us, please put coconut oil. It does help you. So this is a recent study which has come in Nature. And there are other things which patients usually tell us, like aloe, amla, arnica, shikakai, honey, lemon, onion, rita, eucalyptus. These are common things what we have seen. So how do you counsel this patient and what do you tell them? Can they use this or not use this? Dr. Preeti?
So when they elicit this history that they've been trying these home remedies, and you have to find out whether it helped them or it didn't. When they say it worked and it works for a short time, but it of course comes back, I would not tell them to stop it, because at least they have something to do for the time being. And then I would of course add my things to what to continue and maybe give them a mild steroid combination, because these are the inflammatory ones who are not getting relief, and which is why they have come to us. However, if they have no relief from them, you have to tell them to stop, because these are temporary and they are not going to be giving them long-term results. They are not killing the fungus actually. But yes, you know, there are some people who believe in natural therapies. They want Ayurveda. And if you go too much against them, there's a big discussion about how it works and how it doesn't. So I try not to get there. But I would not stop them from doing it if it's helping them. But if it's not helping them, I would stop them for sure.
Do you think oil plays a role in maintaining the barrier function? There is a concept of barrier function also, which is coming on in seborrheic dermatitis also, and maintenance of the scalp microbiome. So do you really think, because it's the last question and patients are leaving after we write our prescription, they usually ask us, can I use hair oil? How often?
Yeah.
So, Dr. Aarti, how do you respond to that?
Now coming to the pathology of seborrheic dermatitis, there is a defect in epidermal barrier which has been recently described. So I advocate oil. I generally ask the patient to apply coconut oil, but not throughout the day. They can just apply half an hour to 2 hours before shampooing. And that is what I generally tell the patients to do. Because if they apply it throughout the day, it can attract a lot of dust, grime, pollutants, and it can lead to an unhealthy scalp.
I would tell them once a week also, same.
Yeah. So how often? Maybe twice a week or daily? I mean, see, this is a difference when the male and female patients come, you know, like, I mean, so Dr. Deepak, any specific?
Ma'am, I think it's same. Like I also advise before taking bath. So it's like once or twice a week.
Twice a week and just for about 2 to 4 hours at the most, not more than that. Okay. So coming on to the topical treatment, which we will go on to all these questions. So we go on to case by case. I think Dr. Deepak has already told on this. Any specific counseling tips on this? Dr. Preeti? I mean, we can use a ketoconazole cream and probably a topical emollient, but any other counseling tips specifically for a cradle cap, because a mother is really anxious about this.
Absolutely. So many times when they are using the massage oils, you know, they massage the babies when they are born. So I would tell them not to do too much on the scalp because it's going to increase their greasiness and make the flakes not come off. I would tell them to use lukewarm water on the scalp to let the scales flake off easily. And we've also tried yogurt, you know, curds, like because it has lactic acid. You hear a lot of children doing, the mothers doing milk and malai for their babies to massage them. So when I've heard from a lot of patients, and I've also had experiences where we've tried yogurt on the scalp to massage the cradle cap, and it helps to exfoliate the scales easily without damaging or without irritating the scalp. So that is one tip which I would like to share, that, you know, we could let them try this home remedy at on their own. But I don't advise antifungal shampoos easily to infants below 1 year, but above 1 year, yes, I would give it. And also I've tried giving a single antifungal fluconazole to the mother, because while she's breastfeeding the child gets the antifungal also through the milk. So it's very diluted and then it works. So these are my ways of handling this.
I ask the patients to actually massage oil, which will help in loosening of the scales, followed by shampooing with a baby shampoo, normal shampoo, or sometimes even ketoconazole shampoos can be used. So this is what I do, and I tell them that it is a self-limiting condition and there will be spontaneous resolution in a few months. So you need not worry about it.
Dr. Deepak?
I usually start with the cetrimide shampoos. So you know, rather than the antifungals, I start with cetrimide for the first 1 week. I'll ask the mother to apply it and leave it for like 10 to 15 minutes. And also I advise oiling for the first 1 week, because as far as this kind of scaling is going to remain on the scalp, the penetration of the topical modalities is going to be very less. So that is what I do. And if I see a lot of inflammation, then I might add topical steroid, but antifungals I usually start after 1 week.
Yeah. So, I mean, would you prefer using a topical steroid or a topical antifungal for this case? I mean, this particular case?
I'll start with the topical corticosteroid. So like desonide, which is very mild potency. So something
usually
like that.
Either hydrocortisone or desonide is what we would use. And maybe later, if it's absolutely not settling, because you can use a topical ketoconazole cream in addition to the oiling and shampoos. It's very important to counsel the mother that it is going to settle anyway between 6 to 8 months of age, because it's going to gradually reduce. That is the most important thing, what we have to tell them. Now, regarding the choice of shampoos and topical treatment, I think we have dealt with how you apply and all. Now, when do you prefer a short contact therapy, and do you advise leave-on therapy for any of the shampoos, and which one? Dr. Preeti?
So the leave-on shampoos would be only like maybe for about 10 minutes with the steroid ones, whereas the others would of course be washed off. I think that's the only thing that I would like to share, that the others are of course, you know, the regular, what Dr. Deepak has mentioned. I would go ahead with the same treatment.
Dr. Aarti, do you advise anyone overnight leave-on antifungal preparation?
Yes, I give thimerosal lotion for overnight application. And in case of moderate to severe seborrheic dermatitis, I advise for a short contact fluocinolone shampoo.
Dr. Deepak?
Same.
Same thing. Even I use flumbazole. How often have you used luliconazole in the current scenario since the molecule has come up?
I've tried it in not many patients, like 2 to 5 patients maybe. And the results are comparable to those of ketoconazole shampoos. So of course, like we need to try it in more and more patients. So
Dr. Preeti?
Same. I've tried it about 5 to 6 patients from the last month, and the results have been good. They've been happy with the, they've got faster results. Like they said earlier, the shampoo would take a little longer, but in the first week itself, they've noticed changes.
Compared to ketoconazole-induced dryness, do you feel any superiority of the shampoo or any other molecule? Especially cyclopyrox. I find cyclopyrox less irritating compared to and dryness compared to ketoconazole. So do you feel that laliconazole also has a similar, maybe the vehicle which is responsible, not the molecule?
It's the vehicle actually, yeah.
How often do you have patients telling you use of tea tree oil application or tea tree oil containing shampoos, and what do you advocate to them?
I've seen patients applying tea tree oil shampoos also. So depending on the the condition of the scalp, most of the time I stop these shampoos because we have better combinations. So usually I go for cyclopyrox or maybe ketoconazole containing shampoos, and now we have an option of laliconazole also. So I usually stop it.
What about selenium sulfide, Dr. Aarti? Are any of us still prescribing it?
I generally prefer ketoconazole over selenium sulfide.
Dr. Preeti?
I've stopped selenium sulfide, yeah.
Same.
I guess.
I mean, do we use Yeah, Dr. Deepak?
Yeah, ma'am, I give selenium sulfide. But usually it is after the ketoconazole. I usually start with ketoconazole or antifungal shampoos, and then I shift towards selenium sulfide.
The steroid-based shampoos mainly, I think we would go more for a severe seborrheic dermatitis not responding. Do you give steroid topical application? I mean, do you combine an antifungal shampoo with a steroid topical application in severe cases?
I do.
Yes. Yes. On the face, yes.
No, on the scalp?
Even on the scalp, I use it. And even in combination with salicylic acid, I've used it, especially with very severe scaling. So I have prescribed the topical steroid with salicylic acid combinations for a week or two, not more than that. And I've also tried these topical calcineurin inhibitors also. So like sometimes the inflammation is not settling and I feel like I need to give it for the longer duration. So like after I stop it for 2 weeks, after I've stopped it after 2 weeks, the topical corticosteroids, I shift towards topical calcineurin inhibitors.
Yeah. So do you give the lotion-based?
Lotion-based.
Lotion-based. Especially when they have lesions only on the forehead, I mean, even the ointment or even the pimecrolimus does work very well. Yeah. I mean, necessarily even psoriasis, even seborrheic, they have a mild on the hair margin. It works very well. And even in the retroauricular area, the calcineurin inhibitor really works well, and the steroid dependence does reduce. What about use of conditioner? Patients often ask this. After their shampoos, do I use a conditioner? Dr. Aarti?
I advocate use of conditioners because it prevents breakage of hair. So yes, if the patient wants to apply conditioner, I let them apply conditioner.
Any other different comments on this?
So conditioners are definitely used for women, and I would tell them to use one clear thing. I tell them shampoo goes above the ears and conditioner goes below the ears. So as long as they're putting their conditioner on the lower hair, it's not going to affect their dandruff or the seborrheic, but they are allowed to use conditioners, yes.
What about concomitant use? Like they use medicated shampoo and then immediately they feel that it's not very good. My hair is very dry, so they want to use another shampoo on top of it, or the oil has not gone off. So do you advocate it?
So I tell them to use the medicated shampoo on the scalp for the seborrhea, but on the rest of the hair, they can use their regular shampoo as a second wash. I let them.
Any comments, Dr. Deepak? Dr.
Ma'am, what I do is usually I tell them alternate day to start with, but sometimes the patient insists that they shampoo it more than twice a week. So then I say maybe maybe if you're applying Monday, Wednesday, Friday, so Tuesday, Thursday, and Saturday they might use their regular shampoo.
Yes,
Dr. Aarti, any comments?
I agree with Dr. Deepak. Generally, I give antifungal shampoos twice a week, and other days, if they want to shampoo, they can use regular shampoos.
Yeah, it's the same thing I do. Now, regarding steroids, topical steroids, I mean, how often do you give clobetasol? And have you used clobetasol foam in any of your patient of seborrheic? We do use it in psoriasis, but have you used it in seborrheic? The foam-based?
I have not used them. I've used it in psoriasis, but seborrheic I have never used.
And fluocinolone?
Fluocinolone and betamethasone. Like I use both of them. Yeah.
Fluocinolone is one of my favorites because it has an oily base also, the one which is available, and it really helps them, helps the patients to reduce the scaling and pruritus. The pruritus, what they complain of, definitely goes down with it. So when do you use systemic agents? Antifungals, I think Dr. Deepak has already mentioned. Any different regimens do you use? I mean, which is your first choice? Is it itraconazole, fluconazole, or terbinafine?
Fluconazole.
Fluconazole, yeah.
Dr. Aarti?
I give itraconazole.
And itraconazole, how long do you give?
Initially,
is it that regimen which is suggested, or is there any change of regimen what you use?
7 to 10 days, yes. Just like the regimen. 7 to 10 days. They can take 2 days a month for a few months.
How often have you used retinoids, Dr. Preeti?
So I haven't tried it, but I know we can give low dose isotretinoin because it can control the sebum production, and that's how the seborrheic will reduce. But I haven't tried it in any of my patients yet.
Dr. Deepak?
I was planning to use Tezaret, actually, tazarotene topical, but I am still to use it in a patient. I've read about it that there are reports of its use in seborrheic dermatitis. Orally, I have never given.
Now we have a halobutazole tazarotene combination which has come up, but I think it's a cream based, so it's difficult to apply. Oral isotretinoin, low dose isotretinoin, recalcitrant seborrheic dermatitis, it definitely helps. You have patients in whom you have given itraconazole for in fact 7 to 10 days, then repeat it monthly. I do give some patients who are very severe, repeat it monthly instead of just 2 days, maybe once a week every month. Even for 2-3 months, they don't respond, then low dose isotretinoin does work in this cases. Do you find any use of role of antibiotics?
Very rarely.
None of you? Dr.
Very rare. Very rare.
Secondary infection, we can give antibiotics.
I somehow feel in certain recalcitrant cases, doxycycline also works. Because see, there is a definite, if you read the recent things also, it tells that there is an alteration in scalp microbiome. And Cutibacterium acnes and Staphylococcus aureus are definitely there. And the proliferation is, the level in which the commensals and these microorganisms are present, it is altered. So in certain cases, recalcitrant cases, when we don't want to give isotretinoin or we don't want to repeatedly give itraconazole, doxycycline also for a short course does help. Are immunosuppressants really required? Any of you? Have you used it for seborrheic dermatitis? Only scalp or no, but extensive all over the body?
Not used.
Not used.
So it is definitely a much less severe disease compared to psoriasis. That's why probably we really don't use immunosuppressants. Now, coming to scalp psoriasis, I think we have discussed with most of the topical things. How often do you give antifungal based shampoos in psoriasis? Dr. Aarti?
Scalp psoriasis, generally I give a combination of steroid and salicylic acid lotion at night, and I give a shampoo containing tar and salicylic acid for scalp wash twice a week. Antifungal shampoos I generally don't give, but if there is a patient with psoriasis, then definitely I'll consider antifungal shampoos.
Dr. Preeti?
I think I'll go with Dr. Aarti, where we've done combination of salicylic and coal tar and steroid, but nothing else.
Dr. Deepak?
Same, ma'am.
Okay. And intralesional, do you really give in scalp psoriasis?
I have given in one of the patients where the psoriasis patch was not resolving. So it does help.
And phototherapy?
Not just for scalp psoriasis, I don't use. But if it is involving rest of the body parts also, then I've used it.
Dr. Aarti?
No, not only for scalp psoriasis, only if it's generalized.
Excimer actually gives good results. I have had experience with both excimer as well as targeted phototherapy. There are certain recalcitrant cases, when we have given all the topical medications, still not responding. Probably the patient is also on apremilast and still not responding. There are certain patches which are very recalcitrant. So both excimer and targeted phototherapy, in fact, excimer is much more better, does work in scalp psoriasis. And systemic therapies, if you have to start, I have a case who is really recalcitrant. Now, this patient has been following up with me since about 10 years. Like, she's already been put on all the topicals going on, been on methotrexate. The only thing she responded to was cyclosporin. And then acitretin was also, I had put her on. Very, very severe scalp psoriasis, absolutely recalcitrant. Unfortunately, she landed up with a tumor, and then she was advised that you cannot take any of the other immunosuppressants. So what do you think? I mean, would you really consider a biologic in such cases for scalp psoriasis?
Important occasion, biologics can be tried.
Pardon?
If there is any important occasion, if suppose a girl is getting married and she wants to get rid of the psoriasis, biologics can be tried in such cases.
Okay. If it comes to systemic therapies, what would be your first therapy of choice?
Methotrexate.
Okay, Dr. Deepak?
Methotrexate only. I've also used cyclosporin also. I've seen good results with apremilast also, though I've used it for like the body psoriasis. But then I've seen like patients improving with their scalp psoriasis also with that. Though like solo scalp psoriasis, I've never used apremilast.
Apremilast does work even in solo scalp psoriasis, is what I have found. I think apremilast and methotrexate is our backbone every time for psoriasis. That's what we would think of. Now, atopic dermatitis, yeah.
Have any of you tried the product Lactium for reducing inflammation, or even evening primrose oil for that matter? In a case of psoriasis and even seborrheic, when there's too much inflammation, I found that these work to calm down the skin, and patients are also more relaxed and more less anxious. Sorry.
You mean the topical application or the oral?
No, these are oral. Lactium is oral, yeah, which helps to. It's basically like an anti-inflammatory agent, and even evening primrose oil helps to hydrate the skin and reduce the flaking. Like I've seen that in psoriasis with my patients. So I wanted to know if any of you have also tried this or heard of it.
Omega-3 fatty acid is something I give for most of my psoriasis or even seborrheic patients, because I do find good results with it.
Yes.
Atopic dermatitis of the scalp alone, have you encountered? Uncommon, but have you?
Not alone. Very uncommon. Maybe I've missed it, but I've never diagnosed alone like atopic dermatitis of the scalp.
What about sensitive scalp? I mean, what would you attribute it? Is it just sensitive scalp, or is it an atopic dermatitis of the scalp?
Usually in children, if you elicit the history, they usually give a history of some oil application for massaging and something like that. So usually I come up with these kind of history of application of something on the scalp that gives rise to the irritation of the scalp. But I'm yet to see a solo atopic dermatitis.
Dr. Aarti?
Or maybe I missed the diagnosis of dermatitis of solely the scalp.
Dr. Preeti?
So I haven't seen atopic dermatitis solely on the scalp, but yes, sensitive scalp, sometimes only itching. There's no lesions, but they're very itchy or they're very oily. These are the things we see with adolescents. And I play with some shampoos, like give them combination shampoos, twice a week this, twice a week that, with steroids, with antifungals, and they found relief. So, but not atopic on its own.
Atopic dermatitis, I think most of this, what I told you earlier also, is adolescents who are childhood atopic, and then they come to you in the adolescence complaining it looks like seborrheic dermatitis, but it is probably actually the atopic and just the dryness which is causing the itching and the problems. That may be just the only manifestation what they're coming with. And the mothers usually come with, my child has dandruff, she keeps on itching, but it's probably an atopic dermatitis which is manifesting. Sensitive scalp, we often get in this middle-aged females who, it may be a hormonal problem issue which will be there, because there is a neuroendocrine mechanism which is definitely responsible in sensitive scalp, and they come with severe complaints of trichodynia, pain and things like that. You wonder whether it is atopic or it is a true sensitive scalp which they are coming with. So it's a condition by itself which has which may present even with scaling. So tinea capitis, I think most of us know. What is your preference now? I think griseofulvin is still the first drug of choice. But if a patient is resistant to griseofulvin or child, I have had few cases who are coming with they've taken treatment of griseofulvin for 1 month, along with fluconazole, and still the carry-on still persistent. So what would be your treatment of choice? Do you use itraconazole often now?
Yes, ma'am, I do use itraconazole after the griseofulvin is not giving the results. Also, like especially in cases of ectothrics only, because whenever I'm encountering endothrix, I would preferably go with the terbinafine. So that is my usual approach: ectothrix, griseofulvin, and then itraconazole. And endothrix is only the terbinafine. So I'm seeing results with these modalities. Topical, I go for something like, whenever there is a inflammatory component, I go for ibuproconazole or maybe a luliconazole kind of topical agents, and along with the oral agents.
Dr. Aarti?
I use ketoconazole, and orally, as Dr. Deepak said, if it is an endothrix infection, then I give terbinafine, and if it is ectothrix, then griseofulvin.
Dr. Preeti?
I'll agree with both of them too.
Okay. And steroids, I think all of us give only in carry-on. How long do you usually give?
The oral therapies one?
Yeah, oral steroids.
Oral steroids I usually taper within 1 or 2 weeks, maximum of 2 weeks.
2 weeks. And how often do you see cicatricial alopecia post carry-on?
I have seen, ma'am. I've seen in 1 or 2 cases. Usually they come late. So the inflammatory component is so severe that sometimes the hair loss it becomes permanent.
Do you prefer using shampoos or you give local topical applications also?
Ma'am, I prefer giving topical applications as compared to the shampoos. Like if I have an option of giving both, then I'll do it both. But if I have to give one, then topical application.
Dr. Aarti?
Overnight application.
How often do you see pigmentation?
Less commonly seen, but yes, like we have encountered.
Okay, so what is your approach to treatment in this case? I mean, amongst all this, suppose this case comes to you.
So in topical keratolytics with the topical steroid and along with the topical antifungal shampoo.
I give a coal tar shampoo for pigmentation.
Okay. Systemic therapy?
I would give antibiotic. I would add an antibiotic because the pathogenic factor here would be Staph aureus, which is causing the pigmentation. So oral antibiotic along with the combination what Dr. Deepak and Dr. Aarti mentioned, I would add maybe an azithromycin or just a short antibiotic course.
What do you consider the underlying cause of pigmentation commonly is? I mean, what you have encountered, few cases.
So it can occur with all these, even seborrheic, even psoriasis, even tinea, all of them can land up into pigmentation because of prolonged and not taking care of the issue, which is why we don't see it too much now because people are so conscious. They'll come to you as soon as something goes wrong on the scalp, but the ones who ignore it, they would land up getting into a pigmentation.
Dr. Aarti, any comments?
I think psoriasis and symptom are the most common underlying causes of pigmentation, and I do not know about the role of antibiotics, and I don't actually prescribe antibiotics for this condition.
Dr. Deepak?
Yeah, seborrheic dermatitis most common. I have done KOH and culture in some of the patients, but except for 1 or 2 patients, I've never seen the reports come out to be positive for fungal elements. So I think seborrheic dermatitis and psoriasis remains over tinea capitis.
Yeah. I think psoriasis and seborrheic is the most common what we see over here compared to tinea when we see a pigmentation. Quite recalcitrant to treatment, many of them are. And ketoconazole work, I mean, before when ketoconazole was available, oral ketoconazole when we used to use, it used to work wonders, even in seborrheic and P. folliculitis. Now, I think past 1 decade, we have stopped using ketoconazole, but it was a very good molecule when we could use it. So even in pigmentation, it was very good. But now I think we are stuck more with topical applications over here, and maybe it may have to be used in some of these cases when it is a seborrheic dermatitis, which is the underlying cause. I think that's all. Any other comments from any of the panelists?
Has anyone tried the metronidazole gel 1% to treat seborrheic dermatitis?
Not me.
Over the face I've used.
Yeah, because it has anti-inflammatory effect. I've seen that works quite well to reduce the redness. So I thought I should share that.
Okay.
Even the role of physic acid has been described. So
I somehow feel seborrheic, we are probably not looking at the bacterial etiology. The scalp microbiome has to be dealt with properly and understood. And that's when probably we'll come to more lasting solution rather than the patient having to use it constantly.
Dr. Vishal, actually, there are 3 questions from the audience.
Yes.
We can
Yes.
take them.
Yeah, I'll just stop sharing my screen. Yeah. I've used Laliconazole shampoo with good result. My worry is long-term side effects as graying of hair as with ketoconazole shampoo. Has this been mentioned in literature, graying of hair? I don't seem to have read it.
I don't think that should be an issue.
Yes.
Can we advise leave-on ketoconazole lotion in babies?
the irritation component is always there first with ketoconazole. So I think it
Absorption
has
in
to
the
be.
baby skin will be high, so I would avoid.
Leave-on, no. Role of mild or daily use shampoos in practice. I think we have already addressed this. Like intermittently, they can use daily or mild shampoos.
Perfect.
Okay. I think we had an interesting discussion.
Yes.
Dr. Dipesh, over to you.
Sure. Thank you, Dr. Vishalakshi, for excellent moderation. And I also thank panelists for sharing, I think, numerous clinical insights on managing various scaly conditions of the scalp. I also thank audience for being interactive during the discussion. Now, before we sign off, I have a small announcement to share with the audience. Chetan, can we have those slides, please? Basically, Lupin has recently launched a product which is relevant to seborrheic dermatitis. It would be the India's first Laliconazole based shampoo. And as Dr. Deepak also mentioned, that Laliconazole actually is a much more potent antifungal when it comes to inhibition of malassezia. And one more common complaint amongst patients using antifungal shampoos, again discussed during the discussion, was that it leads to dryness and irritation. So that part we are trying to take care of using a Aqualock based technology, which is basically using a vegetable conditioner. It has been extracted out of peas, green peas basically, which leads to lesser irritation and dryness and much more easier to apply as well as rinse off. So these are some of the practical benefits of this new offering for seborrheic dermatitis, and we hope it would be useful to dermatologists for managing their patients of seborrheic dermatitis. On this note, I once again thank our panelist, moderator, and the audience, for being part of this meeting. And I hope there was good learning on this relevant topic. Thank you so much. Thank you. Thank you.
Thank you.
Bye.
Thank you.
Bye-bye.
Bye-bye.
Bye. Bye. Bye.
Bye.
Bye.